Thanks, Keith. Welcome, everybody. Great to see everybody virtually, at least. In the great tradition of Medic, we again have an outstanding speaker to help us, address some of the work that, in this case, the pediatric quality initiatives. It's my pleasure to introduce my colleague, Dr. Esther Sampayo from Texas Children's Hospital, Baylor College of Medicine in Houston. Please send us some warm weather whenever you can. Dr. Sampayo completed her residency in Montefiore Children's Hospital in Bronx, New York, and then subsequently completed a pediatric emergency medicine fellowship at the Children's Hospital of Philadelphia. She's currently a program director for the Pediatric Emergency Medicine Fellowship at her institution. More importantly, she's a leader both nationally as well as locally in quality improvement and patient safety. She's here today, and relevant to Medic is that Esther Sampayo is an expert in pediatric asthma continuum care space, and she serves nationally within that role as a chairperson to help develop guidelines as well as clinical care pathways for this particular pediatric asthma care space. Again, she also plays a role under the National American Academy of Pediatrics program called the VIP Network for Pathways for Improving Pediatric Asthma Care, where she is also an expert community coach. So she is definitely the person of the moment for Medic as we consider. So I want to welcome Dr. Sampayo's presentation today, but I also want to remind everybody on the call that if you have a question, please put it in the Q&A. If we don't get to it after the talk, which we will, have a formal Q&A just as Keith went through with Michelle Macy. So just put it in there. If we don't get to it, we will answer it in the follow-up to this meeting. So Esther, I'm going to let you take it away.
Thank you for the introduction, and thank you for inviting me to share my experience with asthma and improving asthma continuums of care in the emergency department. So as always, let's start off with a narrative and think about a very common case. Here you have an 8-year-old male with cough and wheeze that presents to your emergency department. He's been taking his albuterol at home, started off every 4 hours, and now he's been taking it every 2 hours. He has a history of multiple prior ED visits and is currently not on any controller medications. He has some risk factors at home with some smokers and pets. And on exam, you find him to be alert but dyspneic. He's afebrile. He has some moderate work of breathing and otherwise non-focal exam. So this is a very common presentation. This is why we love asthma. It's present in our ER every day of the year, except, during COVID, where we at Texas Children saw a dramatic decrease with our asthma patients throughout the pandemic. We're starting to see a pickup now, and even with kids back in school, our volumes have been significantly lower. So today my focus is going to be really on giving you a little bit of background on how we do some of our QI initiatives here at Texas Children's, but also review some of the evidence-based approaches that are very standard in terms of our standard therapy for mild.
The recording has stopped.
Exacerbations, also reviewing some of the adjunctive therapies that we have at our disposal. But really the focus is going to be on how do we improve ED continuums of care and improve the care of the patients that come through our emergency departments. As we know, asthma is the most common chronic disease of childhood, and our therapies are targeting airflow obstruction, bronchial hyperresponsiveness.
This meeting is being recorded.
It is known as a leading public health problem. I think the screens are frozen. Excuse the technical difficulty. Tech team, it's not advancing. And I'm happy to take any questions if you put them in the chat as we move forward. I will try to incorporate the answers into the presentation, or happy to have a Q&A after the presentation to answer some of those questions. As we know, some of our health statistics, we see many children under 18 years of age with asthma. Our primary focus is this is important because it's a leading cause of hospitalization. And since 2016, we see over 1.6 million asthma visits per year in children, and those numbers haven't significantly changed. And the cost of asthma is significant. And the reason that it's so even more important is that there are a lot of asthma health disparities, which go in line with the previous presentation, because low-income population, minorities, and children living in inner cities experience more emergency department visits, experience more severe hospitalizations, and have a higher mortality due to asthma as compared to the general population. And why is this important? Because we can control asthma. Asthma can be controlled with appropriate diagnosis, care, and management activities. And the emergency department serves as an important access point for patients experiencing asthma exacerbations. And it may be the only source of care for many of our patients if they lack a medical home or primary care provider, thus making the interaction with us in the emergency department even more important. So today we're going to base a lot of the evidence-based recommendations on the National Heart, Lung, and Blood Institute recommendations that were initially published in 2007. It took a really long time for them to update the most recent EPR guidelines, which was published in 2020. Although that recommendation really focuses more on subspecialty improvements and a little bit on controller medications, but not a lot of differences in the acute recommendations for the management of asthma exacerbation. So this is an asthma key driver diagram. This is what our institution uses and developed in order to target our interventions for improving asthma continuums of care. Our aim really focuses on improving the efficiency and effectiveness of asthma care in the emergency department, with the overall goal of reducing asthma-related length of stay, hospitalization, symptom scores, and relapse. And we do this in 5 different phases, where we first look at standardizing our asthma care approach, and then improving the timeliness of stabilization, and then focusing on improving length of stay with early discharge, transitioning our patients to home and self-care, and then focusing on preventing and decreasing revisits to the emergency department or the inpatient service. And I'll kind of take you through this. But before we do that, how do we come up with all these recommendations? And we really focus on clinical system integration and implementation while utilizing data analytics and using our clinical standards with evidence-based medicine. And this is important because as we work in different institutions, many healthcare providers and organizations may practice in silos. So it's so important that we create these meaningful connections and exchange information with other healthcare entities as we're doing today, so we can improve our clinical care operations while maintaining financial boundaries. So what is clinical integration? It's a continuous process of alignment across the care continuum that supports the triple aim of healthcare, which focuses on improving quality of care, reducing controlling the cost of care, and improving access to care, and of course, focusing on the overall patient experience. So today we'll focus on little Johnny and his experience as he transitions through our emergency department. And through the asthma care process team, which is one of the teams that I am co-lead for at Texas Children's, what we have done is incorporated all the different stakeholders that are involved in the care of patients with asthma. But for today, we will be focusing more on the emergency department, but just not to forget that there is a lot of investment from the other areas, including our primary care providers, subspecialists, and those out in the community, including the patient's own self-management, school nurses, and pre-hospital. So our care process team is a disease-specific team that focuses on asthma, and it has structured personnel with expertise in data management, data analysis, epic our EMR expertise. We have a data warehouse architecture, quality improvement, evidence-based practice, and content expertise in those different areas. So we have pulmonologists, allergists, ED physicians, respiratory therapists, social workers, educators, etc., that all come together to create these types of recommendations and pathways for our patients. So if we go back to our key driver diagram, if we think about standardization, one of the first things that we kind of tried to tackle was a team approach to communication by standardizing our asthma scores with the goal of decreasing our time to first beta agonist and first steroid. So if we go back to our patient who's presenting, little Johnny's coming into the ER with this history, what are we going to do for him? What are the first interventions that are going to take place? So if we look at his treatment, this is a copy of the beginning of our Texas Children's Asthma Guidelines. It is what we call the RAMP protocol, which is the Respiratory Assessment and Management Protocol for asthma patients. And as he enters the algorithm, obviously after a brief history and physical exam, he will undergo the numbering of a CRS. A CRS is his clinical respiratory score, and that clinical respiratory score will kind of help guide the provider in determining what course of treatment this child is going to get. So in that first hour, you can see if the child has a CRS greater than 8, they immediately kind of go through that to that more severe path, whereas if they're less than 8, they go into the mild, moderate, or severe category. So this child would fall more into the moderate CRS score. So what is the CRS score? So it is a score that is based on 6 different parameters. It looks at respiratory rate, auscultation, use of accessory muscles, mental status, our room air saturation, and color. And utilizing those parameters, we come up with a score which helps guide the treatment and management of these patients as they come into the EC. We've done a lot of studies on this and have validated it. It's an internal validated score. And what we have shown is that it actually is reliable across a multidisciplinary team. So we have good inter-rater reliability between nurses who initially use the tool, then the respiratory therapists, and then the physicians. And it's a nice way of showing trajectory for these patients. Are they getting better? Are they getting worse? Are they the same? So we have found that this tool has worked very well in our institution and have been using it for over 10 years. Once the child's CRS score is calculated, it is entered into Epic, into a flow sheet, and as you can see, it could be tracked over time. So you can see how the child is performing along with their vital signs throughout the EC visit. We also have little radio buttons that make it easier for the provider to insert the score as they're evaluating the patient and making updates. And all our team members, the nurses, our respiratory therapists, the physicians, use the score to document in the flow sheet throughout the EC stay. So now let's talk about standard therapy. So now you've calculated this respiratory score. You have decided this child has a moderate exacerbation. What is our front line and what is our first line of therapy? So what I want to take you through is just our evidence-based therapies. And our first tiers are usually considered our beta agonists, our anticholinergics such as Atrovent, and our systemic corticosteroids. And those come at our 1A level recommendation. So if we think about SABAs, which are short-acting beta agonists, the recommendation for mild to moderate is to use MDI when available. Usually the recommendation is 4 to 8 puffs, and I will go over an algorithm to determine appropriate dosage. If you are administering albuterol via nebulizer, the recommendation is 0.15 mg per kg per dose. And these treatments are administered every 20 minutes for up to 3 doses in the first hour of arrival. In a child who's coming in extremis or severe, we do the higher dose short-acting beta agonists. Again, either an intermittent or continuous treatment every 20 minutes, or starting them immediately on continuous at 0.5 mg per kg per hour. I I always get questions about, well, how do you differentiate starting a spacer or a nebulizer? This is my daughter. This is now over 10 years old. So it's always a question that we have, and as as a ED physician and as a mom of a child with asthma, it's something that I always questioned. But there's a lot of great evidence out there that shows that there's no difference between the two in terms of hospitalization rates. It's actually better for the ED because you have decreased length of stay in children when you use a spacer, and we have decreased side effects, right? Because you're going directly into the lungs and not having systemic side effects when you use the MDI. So they're at least equivalent to each other. There are some advantages for children with nebulizers, and we'll talk a little bit about that to help you better determine when to use one or the other. So when you use a nebulizer, some of the advantages are that you can deliver oxygen. You don't need to have coordination, which is difficult in children, especially if they're crying, between respiration and aerosol delivery. The dosing is much better established, and it takes a little long of time, right, to get one neb in. Versus the spacer, it's definitely more efficient. It's portable, right? You don't have to require a power source. It entails decreased administration time. There's decreased respiratory therapy costs with that and decreased side effects. And it takes a few seconds per puff if done correctly. So things that you should consider is the patient's severity, right? How many treatments do you think this patient is going to require? Obviously, as we will discuss, the recommendation in a moderate to severe patient is to give concomitant Atrovent or ipratropium, and that is kind of restricts our use to the nebulized portion. So combining those two is why we at Texas Children start off with nebulized treatments for the first 3, so that we're able to administer the ipratropium with it. Because if you use this Atrovent with an MDI spacer, it's single use, it's very expensive, and you can't use it for multiple patients. You also want to consider how the patient is tolerating the device. As I mentioned, it could be institutional preference or availability. And then just remember that deposition is limited by crying and poor MDI technique. But with practice and good education, it works really well. So thinking about all those things will help you kind of determine what works best for your place of practice. I also get a lot of questions on MDI dosing. What are the equivalent doses? Because that we know that for a 17-kilo child, for example, if we have a nebulized treatment that's 0.15 milligrams per kilo, that's equivalent to 2.5 milligrams, which is a vial of a nebulized treatment. If you want to get an equivalent dosing, you can see that if one puff equals 90 micrograms, to get 2.5 milligrams would be 28 puffs, which is ridiculous. So looking at some of the data, equivalent bronchodilation to that neb could be achieved in 6 to 12 puffs by MDI, because there's not a lot of great evidence in terms of dose response. So if we look a little bit at the data, we can see that our changes in FEV1 and improved pulmonary function occurs with the higher dose of the short-acting beta agonist, such as 0.15 mg per kg, with a maximum of 5 milligrams. And that is the recommended dose for these kids every 20 minutes while they're in the EC. This is a nice little chart for your reference. It kind of looks at albuterol dosing from the perspective of a child's weight, and it has the equivalent doses for the doses via nebulizer and converted to dosing for continuous albuterol, and then also for MDI puffs. So you can see for a child over 20 kilos, our nebulized dosing would be 1 milliliter, which is 5 milligrams of albuterol in the nebulizer. And if they required continuous, it would be 20 milligrams per hour and equivalent to 8 puffs. So let's talk a little bit about anticholinergics like Atrovent. So these have been shown to have a big a big effect on patients who come in with moderate to severe exacerbations. The role of an anticholinergic is that it helps relieve bronchomotor tone and decrease mucosal edema and secretions. And studies have shown that when you combine these with our short-acting beta agonists, they may yield enhanced and prolonged bronchodilation. So as part of our guidelines, Atrovent should be used with a beta agonist for at least at most 3 doses as an adjunctive therapy in children with moderate to severe asthma exacerbations. And you can see here in terms of dose response that our FEV1, which is our pulmonary function, improves after 3 doses. And this is just recommended for the ED period of the patient's exacerbation, because evidence has not shown that if you continue this, let's say during hospitalization on the inpatient ward, there's no a change and no improvement. So it is an ED recommended therapy. And the doses that are recommended are 250 micrograms every 20 minutes versus 500 micrograms in the larger child. So as you can see, just to review for these kids, that for anticholinergic treatment by severity, it is efficacious in the moderate to severe patient and highly recommended in all the ED protocols because of the great evidence that it does reduce hospitalization and improve symptom scores. So now let's talk about our other mainstay of treatment for children with asthma. Systemic corticosteroids, this is the classic study in the 1990s that showed when kids received prednisone, they had lower hospitalization rates after 4 hours. And this has taken off and has become the mainstay of treatment for children with acute exacerbations. So the recommendations in terms of the guidelines are if they're presenting with a mild exacerbation, it should be something that should be considered, but definitively administered if they have more of a moderate to severe recommendation. And the recommendation is that it is administered as soon as possible because we start to see those effects at the 4-hour mark. So the earlier we give it, the faster we see those results. And evidence has also showed that the oral route is as efficacious as the IV route, which is another question that we usually get. In those kids that are really severe and you're really worried about their airway, IV is a choice if you're worried about them taking anything oral, but both are as efficacious, whether it's PO or IV. So looking at that data as part of the care process team, we wanted to see how fast we were doing this process. You know, how early is administration of steroids and how fast should we be giving it to get the full effects? Because we know that there has been multiple publications supporting the use of early administration of systemic corticosteroids because there are decreased length of stay, decreased hospitalization, and improved clinical scores. Our institution also did a study looking at implementation of a protocol for EMS providers to give dexamethasone on their way to the EC. And we also saw some great outcomes with decreased hospitalization and improved symptom scores much earlier compared to those who received it in the EC. So as we look to improve timeliness of stabilization, you know, we decided that we were going to transition from prednisone to dexamethasone at the same time because we saw that there was a lot of great studies showing that at least there was comparative effectiveness between the two steroids. And we wanted to see what would be some of the advantages of using dexamethasone over prednisone. And what we found in the studies, you know, as we reviewed the literature, was that there was, you know, they were equal when you look at these forest plots, that there was really no differences or advantages from the outcomes that we were looking for. And there were multiple studies, although they all use different doses, they all use different timing. For the most part, they seem to be equivalent. So the reason that we decided to go with dexamethasone is that it had good oral bioavailability, it had a long biologic half-life, it's also available IM, and it has a stronger potency. So it seemed like the perfect choice. And then looking at some of the other evidence, we saw that there was lower direct and indirect costs associated with administering the dexamethasone, and that most importantly, parents really preferred the use of using 1 to 2 days of steroids as compared to a 5-day course of oral steroids. And then the patients really preferred the taste of using dexamethasone as compared to prednisolone. So that in itself really helped propel our change from prednisone to dexamethasone. So we decided to create this emergency department standing delegation order, which is an SDO, which allowed nurses to look at different criteria. And if the patients met this certain criteria, meaning they were over 2 years old, they had a moderate CRS score, and had asthma, they were able to administer steroids at triage without an order from a physician or an advanced care provider. And our dosing, we also decided to use, because it was just as equivalent as the PO syrup, we used the dexamethasone injection for oral use. And the reason that we went with that is, as you can see, it's 10 milligrams per milliliter. So it's a really small volume. If you use a dexamethasone syrup, it's 1 milligram per milliliter. So you're talking about giving a child 16 mLs of liquid, which is sometimes not very well received. So the lower volume was key in administering this to our patients, and patients tolerated it very well during our triage process. So our loading dose was 0.6 mg per kg with a maximum of 16 milligrams. For those that don't have that available in their institutions, the dexamethasone tablets are really small and easily dissolvable, and you can take the full tablets and dissolve them in about a milliliter of Gatorade or apple juice or water, and that's also easily tolerated. We also were able to create a take-home dose, so our patients would be able to get the second dose while they were in the EC, which was really helpful in terms of compliance and getting their medications in. So over time, with the utilization of our nursing standing delegation order, we were able to kind of meet our goal of over 80% of patients meeting that designation of getting steroids in a more timely fashion. But then, we started to really look at the data and say, okay, all these patients got it within 60 minutes. And what we noticed was that those that got it in the first 15 minutes had decreased hospitalizations. So this is like a little snapshot shots of our asthma click view, which is our data warehouse where we can look at some of our interventions and how we're performing. And you can see, like, if our overall admission rate for some children was 37% in 2021, those who got it within 15 minutes, their admission rate was 2%. So those are pretty significant differences, and we're really excited to get this published because we know now and we can see the consistency that the earlier you get these steroids, the better your outcomes are going to be. So now if we go back to our patient, Johnny, and now we have all our evidence-based data, we have decided that we are going to give him a moderate CRS score as we move forward. In our institution, we have our evidence-based order sets, which have been created to facilitate and get these orders in a timely manner. So we have built an asthma navigator. And within that asthma navigator, we have an order set where a physician can just open the order set and click on it based on the initial CRS. So you can see for this child who has a CRS between 4 and 7, it highlights all the different choices in terms of dexamethasone, your albuterol dosing. It has options for continuous albuterol as well as magnesium. And it also contains all the other different areas that are important to asthma that we will discuss later on. If you forget to use the order set and it's a patient with asthma coming in with asthma chief complaint, it will actually pop up as a best practice alert that this patient may have asthma, and you may want to use the asthma order set as a reminder to utilize that evidence-based order set. So now we've given our patient these treatments. We want to know how they respond to their initial therapy. So he got dexamethasone in triage. He got 3 doses of albuterol, 2 doses of Atrovent. He remains alert and somewhat anxious, SATs are 88%. He still continues to have some mild work of breathing and poor aeration, and then has some louder inspiratory and expiratory wheeze. So what's next for this kid? What are we going to do to treat his asthma exacerbation? So with this child, it seems like he's had some incomplete response. So we have to consider some other adjunctive therapies. And if he were more severe, putting him on continuous albuterol, and then trying to plan our disposition. Is this kid going to need admission? Is he going to need ICU? Is he going to need transfer if you're at a community hospital? So let's talk about this, other adjunctive therapies. Our second tier therapies for asthma include magnesium, and that's what we're going to focus on today because of time. But I always like to bring up sub-Q epi, because I know it's something, for us who have been treating patients for decades, it's always something that is used in the management of asthma traditionally, but really has no evidence-based recommendations. The previous guidelines stated that sub-Q terbutaline or epinephrine should not be used in the treatment of children with asthma exacerbations. However, we know anecdotally and with some newer studies that have come out that in those kids that are coming in extremis with severe status asthmaticus and are not moving air adequately, we go and we grab the epinephrine and give that as one of our first therapies. And with the advent of having our automated, epinephrines for anaphylaxis, we have the 0.15 milligrams or 0.3 milligram epinephrine available, and we can give that IM. So that is something that we do in those patients that are in extremis in the beginning of their emergency department visit. We also get a lot of questions on, how is it better to give the albuterol continuous or intermittently? And studies have shown that those who are placed on continuous albuterol have lower rates of hospitalization and improved pulmonary function scores with similar rates of adverse events and side effects, such as palpitations and so on. So when we think about our short-acting beta agonists, just to review, in the moderate patient, giving it every 20 minutes for 3 doses, and then reassessing is important. And then just to review, in severe continuous nebulization and adding the ipratropium and not forgetting that improves our outcomes in severe asthma. So how about magnesium? So magnesium sulfate, the mechanism of action is that it is a smooth muscle relaxant and that inhibits mast cell degranulation and mitigates the inflammation that we commonly see in asthma. Many studies have showed that it improves pulmonary function, improves symptom scores, and importantly, reduces hospitalizations with a number needed to treat of 5. So our evidence-based guidelines recommend the use of IV magnesium sulfate as an adjunct in the first hour when there's inadequate response to conventional therapy in children with moderate to severe exacerbations. Again, if the kid comes in extremis and they're very severe at the initial onset, you can start it right away. But if they're not responding to the traditional 3 back-to-back albuterol Atrovents and they're not improving, it is considered the next goal of therapy. And that is because we've had really great studies that have shown improved pulmonary function tests with our patients. And they're even greater when you use a higher dose of magnesium. So the recommended dose is 40 to 50 milligrams per kilo with a maximum of 2 grams. And you can see in these studies that have been done over time that the magnesium sulfate is favored in terms of preventing hospitalization. So when we think about our child Johnny and the doses of albuterol that he's received and how he has not really improved, we go to our asthma pathway, and that we see that he needs to get IV magnesium and continuous albuterol. And many people
The recording has stopped.
And many people will ask, well, what about a chest X-ray? Is that something that we need to consider in this child who initially is not responding to traditional treatment? And the answer to this is no. In our guidelines, it'll show you that if you go ahead and order X-ray, there are reasons, to order X-rays if you're concerned about pneumonia or pneumothorax or have signs. But for the most part, we know that the evidence is that for children with traditional asthma exacerbation status asthmaticus, evidence suggests that pneumonia and other abnormalities that are going to affect the treatment of this child is less than 5%. So I've seen tons of chest X-rays on asthmatics, and it really rarely changes management. So it's something that we really try to track as something that's cost effective and reduces radiation in kids. We also don't routinely recommend serum potassiums in these children after receiving initial doses of albuterol. So it is something that we check on our QlikView data warehouse as well. And you can see, our rates started to go up in 2020 because of the pandemic and because of other worries with COVID and pneumonia. But for the most part, our goal is to stay under 25% of our patients getting X-rays. So our kid got a 50 milligram bolus of magnesium. He was placed on continuous for a couple of hours. He seemed to become more interactive with improving aeration and work of breathing and standing well on room air. He was observed for 3 hours. His CRS score decreased to 1. And we kind of follow our guidelines, which starts prepping him for discharge home. So that's what the next thing we're going to focus on is how do we prepare these children to go home and how do we transition them to self-care? So if we look at the national guidelines, there are recommendations that ED providers should consider initiating controller medications, but there's really not a lot of great evidence to support this recommendation. And when you poll emergency medicine physicians, we are at the lowest tier to prescribe these medications during the ED. So many years ago, I was really interested in this topic, and we looked at different surveys and saw that ED physicians infrequently prescribe inhaled corticosteroids, and less than 20% of us did. And we asked why. And most importantly, people felt that, we are not the primary care. This is not our role. This is not our responsibility. We're unable to provide long-term management or follow-up for these medications. So folks really felt uncomfortable taking on this responsibility. We did studies that looked at if the emergency medicine physician started controllers, it was more likely to be continued by their primary care provider. And we also surveyed pediatricians nationally through the AAP, and many pediatricians supported and welcomed this practice because they saw the ED as a window of opportunity to get these patients started on the correct medication. And we also did studies to show that it doesn't really impact PCP follow-up, and patients still follow up with their primary care providers and don't use the emergency department as their primary care medical home. And what we can see, there are also some short-term benefits of starting kids on controller medicines. There's been a few studies that have looked at patients after the ED visit who were started on controllers, and you can see that they have decreased symptoms in the immediate period following the ED visit. They had decreased cough, decreased wheeze, decreased missed school days. So there is some importance in terms of not only long-term control, but also on improving their short-term outcomes and improving their symptom scores and quality of life measures immediately after the emergency department visit. So we developed a short tool that we can utilize in the emergency department because we know as emergency providers, we are busy. We don't have a lot of time. We're multitasking. We don't have a lot of time to be sitting around asking all the persistent asthma questions. So we narrowed it down to 3 questions. So if your patient's having symptoms with running of sports, while asleep at night, if he's taking his albuterol a lot during the week, if they have a checkbox anywhere in the gray, they are considered persistent and therefore candidates for having a controller medication. We also incorporated these questions into our EC Navigator. So in addition to the clinical respiratory score, we have a severity score, which kind of prompts the provider to ask these questions to help them label their patient, whether they have intermittent or persistent asthma. We've also incorporated goals, which are kind of instructions and asthma care plans, which are easily accessible, and within seconds you can create one for the patient's discharge. This is what one of the asthma action plans look like. They're available in English and Spanish, and they are all standardized. So that's something that we did as an institution through the care process team. We realized there were over 300 different versions of care plans, which you can imagine is very confusing for families if they get one from their PCP, one from the ER, one from their pulmonologist, and they're all different. So we all came together and standardized our asthma action plan for standard dosing. And all you have to do when you go into our EMR is click on that yellow controller area, and it gives you the options of what you have to choose. And with one click, you have your asthma action plan completed. And with a second click, it is incorporated into the ABS for the patient's discharge. We also have a best practice alert, which alerts the provider if this patient has persistent asthma and they're not on controller medication, kind of like a reminder in the navigator. It's not a hard stop. We don't have those in our EMR because we know, if we have a child in extremis, we don't want these things popping up, but it is there when they open the navigator, when they're discharge planning their patient. We also have incorporated a best practice alert for influenza vaccination. So this is an opportunity for us to vaccinate our children as they come into the ER, and that has also been very successful and reducing, hopefully, hospitalizations and EC visits in the future. So when we think about asthma in terms of its acute management, really the focus is on our standard triple therapy for those patients when they initially come in. Utilizing our short-acting beta agonists with an MDI and spacer for mild and moderate, and utilizing high dose or continuous for moderate severe. Not forgetting to use our anticholinergic for 2 to 3 doses in those patients that come in with moderate to severe exacerbations, and then the timely administration of our systemic corticosteroids for those patients, as well as remembering our adjunctive therapy and continuous albuterol and early administration of magnesium sulfate if they are not improving with your traditional triple therapy. In terms of discharge to home, we always advise our patients to follow up in 1 week. We want to remember if there's opportunities for education and going over environmental triggers, and then making sure that they have all their discharge instructions for medication use, which includes using albuterol every 4 hours for the next 24 to 48 hours, getting their dexamethasone for home, a prescription or a refill for their controller medication, a flu vaccination if they're eligible, and then instructions and anticipatory guidance on when to return. And for those patients who need referral to a subspecialty or high-risk asthma clinic, we'll talk a little bit about a way of getting them hooked up into the system. So just in terms of future directions for our team, some of the things that we're looking at is predictive analytics and trying to pick out which one of our patients need a little bit more referral, need a little bit more help. So our Texas Children's Health Plan has developed a tool that can predict asthma crisis risk. And it looks at asthma hospitalizations, how many ED visits they have, if they're overusing their short beta agonists, if they're underusing their inhaled corticosteroids, and if they're seeing multiple providers and they have fragmentation of care. So this is like next on the horizon, and I'm really excited because these high-risk reports that are built into the Navigator kind of give you that information that you need to know when you need to refer these patients to a higher level of care. And this risk score incorporates all these different points and comes up as a flag that this patient is high risk. And it is in use in our primary care offices, and we will be activating it in our EC and inpatient more for the use of, getting these patients referrals or just being a little bit more conservative. Like maybe they do need to be hospitalized, maybe they need a little bit more time. So I think it'll be very helpful for us in the emergency department role as well. I also wanted to highlight some other resources for you. We were part of the Children's Hospital Association Collaborative, which is a collaborative of all the children's hospitals in Texas, and we developed collaboratively this asthma management pathway. You can see that there's a hyperlink there for your reference, and what it does is it takes all the recommendations that we just went over, and it is based on, again, the first hour, second hour, third hour of the ED visit approach. Each area that is underlined has a hyperlink with recommendations and evidence-based references. So if you were to click on anything that's underlined, for the most part, you would have access. Some of the hyperlinks are restricted to chat members, but for the most part, the medication recommendations and references are available to you, and it's a very easy to use pathway. So I recommend you taking a look and see what you think. So just, we wanted to thank you for listening and learning about our processes at Texas Children's. We're really excited about the work that we're doing on the acute side, but also cognizant of all the important work that's being done on the chronic and community side, so that ultimately we can work on improving continuums of care for our patients, and that will in turn lead to improved clinical outcomes. So if we take a combination of getting good metrics to improve our outcomes with a goal of decreasing our ED visits and decreasing hospitalizations, with our primary goal of improving asthma control and quality of life for our patients, I think, we're trying to do a good job for these patients and in terms of their management. So I wanted to thank you guys, everyone, for listening, and I'm happy. I see there are some questions in the Q&A. I'm happy to answer questions. The first question was, do you think the drop in ED visits is due in part to parents' fears that they or their children will contract COVID if they go in? Honestly, we've looked at that, and I think it's a combination of factors. The fact that there's such good hand hygiene, the fact that people, that children are not giving each other rhinovirus, which was one of the bugs that we've been seeing a lot in the ED, in addition to, the parents now coming into the ED. But we found with our colleagues in pediatrics that they're just not getting exacerbation. So whether, I think it's a multifactorial reason, but it was just very interesting that this has been a trend throughout the United States. I also see a question, when treating pediatrics children with asthma, are there any age weight related limits that need to be considered? So no, I think we administer albuterol in young infants. I think we use the lower end of 2.5 for these children, but albuterol is pretty safe, and there really are no restrictions. If you do the 0.15 mg per kg, you are in the safe zone. Thank you.
Dr. Sampayo, thank you so very much. This was a fabulous talk. And we have a couple of questions from the coordinating center. And thank you for self-serving your questions there. That was awesome. First of all, you know, it's obvious to us that you have really leveraged your EHR to drive your improvement by both getting data as well as, you know, providing a format for physicians to have and monitor what they're doing and get fed things, as well as harnessing your nursing staff to give things early. So we kind of, you know, in the coordinating center, we know, and I'm just going to ask because of your experience working in the community settings too, we all have sort of different challenges in our ability to use the EHR to the degree that we would love to use it. So if you had your choice of like, where are the big wins in trying to promote safe discharge of children with asthma from your emergency department, where would you put, you know, your force and your energy?
I think the order sets are really helpful because it helps to standardize treatment. So I went over our treatment order set, but I find that we also have a discharge order set, which designates everything that needs to be done. So with a quick click, you can just easily standardize your therapies that the patient needs and kind of help promote that discharge from the beginning, right? So it has little segues for clicking on your asthma action plan, clicking on your controller, clicking on follow up with your pediatrician, and all that transitions into the ABS, which is their discharge paperwork that the nurse can review with them upon discharge. So it's very easy. You can do it at any point during the ED stay. And I think the luxury that we forget, you know, these patients stay with us for a little while, right, in the EC, because they're spacing, because they're getting multiple therapies. So we have some time and wiggle room to really adjust our therapies and our orders early on in the ED visit so that when they're ready to go, they can go, and we're not delaying that discharge.
So I'm going to ask one corollary question. That question, I'm going to open it up to my team here too. You have used a delivery system of steroids by the nursing staff really at triage. I was just wondering how you managed to do that. What are the strategies that others of us can use to try to grab that stakeholder and try to get that done?
Yes, that has been a work of passion over the past few years, and it has been so important to have nursing buy-in. And I think giving them this data, you know, continuously has been very helpful. So when they see that they can make a difference, so hey, if you give it early, you can reduce hospitalization, you can reduce those outcomes. That is really, you know, been very beneficial. I think there are a lot of political and other kind of administrative constraints with that type of administration. Like I mentioned, we initially had a standing delegation order. Over time, that transitioned to a verbal order that they required the MD or PA or NP to give a verbal order for the medication to align more with nursing contracts. Because many felt that it was out of the scope for a nurse to order a medication without consulting with a physician. But what we, you know, kind of rebutted was that they are looking at the standing delegation order, which is a platform and gives the recommendations for who is eligible. They're not just deciding who gets it. If they meet eligibility, then that in itself meets the criteria, and we've been able to utilize that with a verbal order to continue the administration during the triage process.
Thanks. It'll be super helpful to our team. I wanted to open it up. I believe someone on our team had a question. Megan?
Yep, there's one question here from the audience wondering what is the benefit of using the CRS score over the PASS score?
There's no benefit. I think the PASS score, there are multiple scores that have been validated throughout for the use of asthma. I think you have to use what best meets your institution. For us, it was an institutional score that was generated, and we got very comfortable using it. If you look at the website for the chat, it has all the different scores available there with the evidence behind them, and you can choose the one that best fits your pathway. So there are multiple scores that are used in the acute exacerbations, and this is just something that was homegrown, and we have gotten so much experience with it from a multidisciplinary perspective that it has worked well for us. But yes, there are other great scores that you can utilize. I think the key is to have it standardized so that you all are speaking the same language, and it makes it a lot easier to see what the trajectory is for this child, if they're getting better, if they're getting worse, when you're signing off to someone else or passing it on in terms of admission.
Thank you. We have another question here. Wondering, what was the process of acceptance for nurse-initiated ordering for steroids in order to promote earlier treatment? And as a corollary to that, were there any barriers with hospital administration or legal on that front?
Yes, as we discussed, there were some legal ramifications from nursing, which is why we transitioned to the verbal order, and thus requiring the nurse to ask the physician, can I give these steroids? These kids meet the criteria. We also kind of bypass that by having APP at triage for most of the day, where they're doing medical screening exams, and they're there when the patients come in, so that they're able to give those verbal orders to administer steroids. But yes, there are a lot of nursing board legal ramifications, and our hope is, if we show that it is a safe practice, which we have a lot of data on, and the fact that it actually reduces cost and it reduces hospitalization, that we can hopefully, we're working with legal to get that standard delegation order back on track the way that it was initially proposed.
Okay, we have a couple other follow-up questions for you, Esther. My question to you is, what is your strategy for taking all the information? I know that there are graphs and analytic and dashboards and things, probably your institution. How does the rank and file emergency medicine physician know how they're performing, and what do they have access to, or how do you strategize how to give them information to make sure you're on track and moving forward?
That's a great question. So as part of our care process team, we meet weekly, and the first Wednesday of the month is our acute asthma meeting, which really focuses on EC and inpatient, and we review the data, and then we have key stakeholders that disseminate those minutes from those meetings to show performance. So we have RTs, we have nursing, we have physicians, and we give kind of feedback. And depending on what point we are on the QI project, we can give individual feedback based on the provider. So, hey, we saw that you missed some, influenza vaccination opportunities on these patients, or controller medication. So we can give direct feedback with the data that we have. So we really have relied on having a dashboard. We are working on getting more automated information, so we have some reports. So when we started the steroid timeliness, our ClickView allowed for reports that are based on our campus, since we have 3 campuses, and that was disseminated to those key stakeholders every 2 weeks. And we found that that was really helpful in keeping people on track.
Excellent. And then just to clarify, so right now the individual physicians do not see a dashboard, but the key stakeholder in your unit does have a dashboard.
We have one for the centralized team, and then we disseminate information from that to everyone else. So we don't have one as of yet, but that's something that is in the works.
Okay. Thank you very much. This has been a terrific talk and extremely well aligned with the, our overall safe discharge plan. One moment, I think we have a late breaking question for you.
Yep, we have 2 additional questions. So one is asking how many people are on your asthma team, Dr. Sampayo?
Ooh, it really depends on the meeting. So we have our acute team and we have our chronic team. But for the most part, we have at least 10 to 15 people on each meeting. And depending on the topic, we'll bring in different stakeholders. So if we're focusing on therapies, we'll have pharmacy constituents come in. If we're focusing on something like educational, we'll have our educational person come in. So we have a big list, and then we can capture depending on the topic.
Thank you. And then one final question here. Any advice you'd give for doing this QI work in the community emergency department setting?
I think that's a great idea. I think there's many opportunities. There's many papers. If you look at PIPA from the AAP, it's valued inpatient pediatrics. We did a lot of interventions in community hospitals, and we found that the most important influence was having a coach. So having a coach from a place that has had experience in QI work was one of the most important features in helping the community hospital be engaged and successful in their QI interventions. So I highly recommend that. And if you look up those papers, there's some really good, as a nice qualitative study that we did that highlights some of the initiatives that you can take in a community hospital to improve asthma continuums of care.
Thank you. I think that rounds out our question session. And again, Dr. Sampayo, we want to say thank you again. This has just been extremely timely. And I want to just thank you again from all of us that, you've spent your time with us. You're welcome to stay for this afternoon's content. So please feel free to do so. For our overall Medic Collaborative, we want to, at this point, take a quick 5-minute break. It's 10:55, so we will reconvene here at 11 o'clock. So feel free to go get your coffee or other caffeinated beverage, and we'll see you back in just a few minutes. Thank you.